Hello, everyone, and welcome to this webinar by the European DBT Association. My name is Jan Hilbig. I'm a psychiatrist and psychotherapist based in Vilnius, Lithuania, and I will be moderating this webinar. Tonight, the webinar is about mechanism of change in DBT, and our speaker is Shelley McMain. Shelley is head of the Borderline Personality Disorder Clinic, and she's also a senior scientist at the Center for Addiction and Mental Health in Toronto, Canada. She's also an associate professor of the Department of Psychiatry at the University of Toronto, and her research focuses mainly on psychotherapy. In that field, her special interests are DBT, personality disorders, and also trauma. Shelley is also founder and co-director of the Center for Mind and Body Health, a private psychotherapy center in Toronto. And she also serves as past president of the World DBT Association. The structure of this webinar is such that Shelley will give an introduction into the topic. It will last around, that's approximately 45 minutes. And then after that, we have some time for discussion, and you can participate in that by putting your questions into the chat field, into the chat function you find on YouTube. And I will be following those questions and then hand them over to Shelley for us to have that discussion. There will also be a video recording later available on YouTube and the EDBTA website. Shelley, we are very honored and happy to have you, and I would just give the word to you now to continue. It's great to have you here.
Thank you, Jan, for your very nice introduction, and happy to be here to speak about mechanisms in dialectical behavior therapy. So I hope you can see my screen. Just a little roadmap to explain where I'm going to focus today. I thought I'd start by saying a little bit about what do we actually mean by mechanisms, how do we study them, and I want to focus on some key areas of focus in this area. I will be discussing sort of select studies from these key areas to illustrate these points. This by no means is going to be an exhaustive review. There's only so much that can be covered in 45 minutes, but hopefully we'll give you some idea of what's happening in this area. So just so we're clear on what do we mean by mechanisms, it's really mechanisms of action. It's just a fancy way of asking ourselves, what's actually causing change in treatment? Really, what are the active ingredients or elements of the intervention that are really driving change on outcomes? And really the processes inside the therapy responsible for change. It's not just what technique we're using, but really what is it that is responsible for change within a particular technique. So just by way of an analogy, I'll use this one, I've used this one before, but if you think about the experience of having brain freeze as a result of eating ice cream really fast. We've all probably had this experience. It's not random, but it does come from a very specific chain of reactions. If you're eating ice cream very fast, the cold hits the roof of your mouth and the blood vessels rapidly constrict and then widen. And it's this sudden change in blood flow that the brain interprets as pain. So the key point is the experience of pain is produced by this underlying mechanism. This can all be moderated by how quickly you're eating ice cream. The faster you eat ice cream, the more likely you'll have that brain freeze phenomenon. So moving beyond the question about why does DBT work, and we certainly have lots of research that shows that DBT is an effective treatment. And now, like other therapeutic approaches, the question that people are asking is, for whom does it work and how does it work? And this is a question that Paul Gordon asked back in 1969. A more contemporary question posed by Hoffman and Hayes is, what core biopsychosocial processes should be targeted with this client, given this goal in this situation, and how can they be most efficiently and effectively changed? So there's a lot of good reasons why we want to understand mechanisms. Certainly understanding mechanisms of action allows us to refine and improve upon our treatments. If we can optimize our treatments by utilizing the elements that are really driving change, we can eliminate aspects of the treatment that may not be so useful. It's also potentially a really useful way to personalize treatment if we understand specific processes may be more amenable to change through specific interventions. We can tailor our treatments better to specific clients. And it's also a way to improve implementation of the treatment. Now, DBT is multifaceted. We know this, we know it's complex. There's many different interventions in the treatment. It likely works through multiple interacting mechanisms. So it's unlikely that one key mechanism is driving change. So if we consider stepping back and consider the theory of DBT and the theory of the treatment, the theory of pathology, we know that DBT is founded on the theory or assumption that the core problem to be addressed is the problem of pervasive emotion dysregulation. And the core mechanism of treatment is to address pervasive emotion dysregulation by reducing emotion-driven responding, ineffective behaviors by strengthening emotion regulation capacities. And there's really 4 key mechanisms theorized to drive outcome change. There may be others, but I think these are key ones. One is the enhancement of attentional control. So, for example, mindfulness is a way of increasing focus and control of attention. It's a way to disengage from intense emotional experience, to step back from, decenter. Emotion modulation, another mechanism, is about building the capacity to influence emotional responses, turn the volume up on maybe emotions that are being suppressed or inhibited, or turn the volume down on emotions that are too intense. Awareness and acceptance of emotions involves noticing, allowing of emotional experience and reducing the suppression of emotions. It allows for more flexible responding. And the building of adaptive skills, the sort of 4th key mechanism, involves replacing maladaptive ways of coping with more functional ways of coping. Building skills is certainly a key way in DBT. And there's a variety of interventions that I think are really designed to address these mechanisms. You know, for example, if we just consider what's the presumed function of validation, presumably that lowers emotional arousal, allows people to be open to new learning, enhances their ability to become aware of and accept experiences, and opens them to new learning. So there are a variety of approaches to studying change mechanisms, and I want to highlight these because I think it's important just to be aware of the different methods of studying mechanisms, since they have implications for understanding the research in this area. So mediation analyses is a very common way of studying mechanisms. It's a method of testing statistical pathways, but it's not a true test of a mechanism. It shows correlational and temporal ordering, but it doesn't actually tell us about causal processes. Many studies are based on temporal or longitudinal models, and this is where we check to see if there's been a change in a particular variable over time, and does that change precede change on outcome. There's also some research that involves a study of very micro process level, for example, change in emotional expression or change in perhaps the resolution of an alliance rupture. This can be captured through EMA, so ecological momentary assessments, or it might be captured. Some researchers are studying transcripts or studying videotapes of therapy sessions and capturing moment-to-moment changes. Other methods include qualitative and mixed methods, so kind of revealing really live mechanisms that might not be captured by self-reports. Network analysis is sort of a newer and emerging area where you can model symptoms as processes as a dynamic system. And then experimental manipulation, and this has really been studied far less. This has got the strongest causal evidence, but it might include sort of dismantling and testing specific interventions or strategies and their impact on change on specific processes and outcomes. So the field is increasingly, I think, emphasizing a clear distinction between variables that merely show up as a mediator, so a statistic in a statistical model, and actual causal processes that drive change. So much of the DBT research has largely focused on the client and processes within the client, and has focused on psychological processes. And so I've decided to keep my focus on these areas. There are other areas that I'm not covering, for example, physiological and biological variables, and there's probably less research in that area, but we need more time to cover all of this. So what I will be focusing on areas that have received the most attention, and these are studies that have examined coping skill use in addition, so broad general coping skill use, and in particular mindfulness and attentional control. Also studies that have examined emotion processes and the regulation of emotions. And then the other area that's really received a fair bit of attention is the therapeutic alliance and validation. So I'll start by sharing a bit about coping skill use. We all know that if you're familiar with DBT, you know it starts with a really simple idea, a deficit model that people haven't learned functional ways to respond as a consequence of their own learning history. And they tend to struggle in 4 main areas. So mindfulness, emotion regulation, interpersonal skills, and distress tolerance are areas of primary deficit. And so because these skills aren't naturally available, people tend to turn to quick fixes to reduce their own emotional distress, aversive emotions in the moment. But of course, those strategies that they may use cause problems later. So hence our focus on teaching people practical skills in DBT. So what do we actually know about whether or not teaching people coping skills may be a mechanism of change? So we do know there's been several studies that have examined this, and certainly the evidence shows that the use of skills matters. So clients who are practicing more DBT skills have been found to show greater reductions in their suicide and non-suicidal behavior. There's also several studies that have showed that as clients increase their adaptive coping, so really purposeful, adaptive responding to situations, this is predictive of improvement. It's been found that the development of more functional coping behaviors has been found to mediate improvement in symptoms. As well, the reduction in more maladaptive ways of coping has been found to be associated with improvements in borderline symptoms and in depression symptoms. So the bottom line here is across these studies that if clients are using skills and using them consistently, this seems to predict better outcomes in DBT. Now, another consistent finding, and this is from several studies on really tests of whether The increase in skill use is a mediator of outcomes, and there's been several studies that have found that increasing in functional skills, functional coping, is associated with reductions in suicide attempts, reductions in non-suicidal self-injury, lower depression, improvements in anger. So across a broad range of symptoms. There's also evidence that DBT skills training outperforms control in terms of boosting skills and reducing emotion dysregulation and anxiety, and that the use of skills is a mediator of outcomes. Another study, and this was a 12-week study of DBT skills, found that as participants were reducing their dysfunctional coping, that was found to mediate improvements in borderline symptoms and outcomes. So the bottom line is that the use of skills is a driver of change. If we look at whether or not DBT skills is connected to outcomes across other studies, we see again more adaptive coping is associated with a reduction in borderline symptoms. Importantly, the more frequent use of skills has also been found to be associated with reductions in self-harm, lower dropout rates. And what's interesting in one study is that the increase of skill use predicted outcomes, and that was over and above the contribution of the alliance and on treatment credibility. So that's important since we know alliance has been found to predict outcomes, but this was over and above the contributions of the alliance. So there's also another study that I think had a really important finding, and this was a DBT partial hospitalization program. What they found was that increase of skill use was predictive of improvements in symptoms such as eating disorder symptoms and depression and emotion dysregulation. And I think what was really important about this study is that this was especially true in the first 4 weeks of treatment. So it was that early change that seemed to explain more of the outcome change later on. Other studies have, again, consistent with these findings, found that, again, as skill use is increasing, it's predictive of reductions in general mental health symptoms and emotion dysregulation. And there was another study conducted, and this was with an adolescent population. I think this finding was interesting because they found that specifically increases in interpersonal skills and the emotion regulation skills relative to the other skill modules predicted decreases in depression and anxiety. So it may be that, for example, the interpersonal and emotion regulation skills may have aligned better with the developmental needs of the adolescents. I think the bottom line is that there's evidence that increasing adaptive coping, and maybe especially early in treatment, seems to be a consistent driver of change across several DBT programs. Clinically, there's also some indication that prioritizing early reinforcement of skill use might be especially important because, maybe you can catch momentum quite early on. And it may be that with adolescents, the interpersonal skills and the emotion regulation skills may be really important because they seem to be perhaps more aligned with developmental needs. Now, if we look at specific skill modules or skills, and we consider mindfulness, a lot of research has focused on mindfulness. And there's certainly consistent evidence that the increase of awareness And the ability to decenter, so the ability to step back and be able to step out of the movie, so to speak, and look at it, is a consistent predictor of reduction in symptoms. It is associated with reductions in borderline symptoms, reductions in depression, and reductions in overall symptom distress. We did a study a while ago looking at whether or not mindfulness and distress tolerance mediate change on outcomes. And this was in a DBT skills group, a 20-week DBT skills groups for people with borderline personality disorder. We found that as improvements in mindfulness, even independent of gains made in distress tolerance, were associated with improvements in outcome. There's also evidence again that shows that the frequency of practice, so again, we're sort of seeing this finding that the more frequent people are practicing is predictive of greater reductions in BPD symptoms. So, takeaway, it seems, is that increasing people's ability to be aware, to be able to decenter, seem to be key drivers of symptom change in DBT. Now, there have been several studies looking at various facets of mindfulness. And, we know that mindfulness is a pretty broad construct, and there have been several commonly described facets in DBT that overlap, in DBT, but overlap with other research descriptions of mindfulness, such as the ability to observe, the ability to describe, the ability to act without awareness, the ability to be non-judgmental of inner experience and be not reactive to inner experience. And what seems to consistently emerge from many of these studies is the finding that acceptance without judgment seems to be a very important facet of mindfulness and a very strong predictor of improvement across several DBT studies. So, for example, there's a study that found that as acceptance without judgment increased, it was associated with reductions in borderline symptoms. This was even after controlling for depression and hopelessness. Another study found that acceptance without judgment was predictive of fewer hospital days. And another study that I was involved in found that acceptance without judgment was a unique mediator of the link between DBT skills training and decreases in non-suicidal self-injury. Now, why is it that non-judgment may be particularly critical to change on outcomes? I think certainly non-judgment is a really, potentially effective way to reduce secondary emotional escalation. If I'm not judging myself as an idiot, I'm less likely to feel depressed. It's also an effective antidote to experiential avoidance. If I'm not judging, I'm actually exposing myself to my primary emotions. That allows for acceptance of those emotions and cognitive reprocessing. And non-judgment it really encourages, I think, curiosity and openness. It allows new meaning and allows emotion to be felt without, adding shame or self-criticism. So there may be a lot of good reasons why that dimension of mindfulness is particularly important. So I want to turn to emotion regulation, some studies on emotion regulation processes, and several studies have examined emotion processes and found that there are specific changes that seem to be predictive of change on outcomes. So one finding that has emerged is that as people are less avoidant of their emotions, that is predictive of lower levels of depression. We did a study earlier on. This was in a sample of patients with borderline personality disorder. And we found that as people increase their ability to identify and describe their emotional experience, in addition to improving their overall emotional balance, so the degree to which they experience positive and negative emotions, that both improvements in emotional balance and the ability to identify and describe emotional experience was predictive of better improvements on symptoms and also changes in interpersonal functioning. And that was true in both a DBT condition as well as a general psychiatric condition. So this may be a trans-theoretical mechanism. A study by Seth Axelrod examined substance users, and he found that in a substance using population, as patients were improving their ability to regulate their emotions, that explained their reductions in substance use. And that's important. Certainly, there's many theories that talk about substance use as a problem that serves or functions to regulate emotions. So it theoretically makes sense. So once emotion regulation improved in this sample, there was this improvement in overall substance use. Another really interesting study done by Uli Kramer, and this really examined, there's few of these studies, but it involved really an examination of microprocesses of changes in emotional expression. And this was done by coding live sessions or videotapes of sessions. And it was, the study was conducted in a DBT Informed program. It was a skills only, but they found that as participants or as patients in this group increase their expression of adaptive and assertive anger, there was a change in their overall reduction of symptoms. So there was no change in their overall rejecting anger. So what's the takeaway, I think, from these studies? First, I think there's evidence that improvements in overall emotion regulation, so not just knowledge of skills or practice of skills, is driving change in reductions of depression, BPD symptoms, substance use, and also dysfunctional anger. There is a more recent study, and I'm sorry, I don't seem to have the reference for this, so I'm sorry, I'll have to get this, but this was done in the past 2 years. So this study uses more advanced statistical techniques. There's not a lot of these network analyses, but this was an effort on the researchers' part to try and model borderline symptoms as a dynamic network of symptoms. So where each symptom influences and sustains others. And these researchers use 2 approaches. So they both use computer simulations to look at how do symptoms change, how are they connected, and how do individual symptoms influence the overall system. But what was interesting is they also used in vivo intervention. So they looked at a real world analysis of DBT skills training, and they examined borderline symptoms using the BEST. It's a self-report instrument to measure symptom changes before and after therapy. And maybe just to say, some people may be less familiar with network analysis, but it's a really nice way to understand problems by looking at how things are connected, which probably is a more useful approach because things are complex and interconnected, but you might think of it as a bit of a Christmas tree with lights. If you imagine a Christmas tree and you've got a lot of bulbs on the tree and you think of those bulbs as a symptom, and then you've got wires that connect the bulbs. If you get one bulb on your Christmas tree that's flickering, you might have another flicker also. Well, your network analysis helps you figure out which is the bulb that's causing the most trouble. You know, where is the wiring a bit tangled, or which fix in the bulb or the wiring are going to make the whole strand bright. So the goal is to try and untangle the wire and not just replace one bulb. And if you think of symptoms, obviously symptoms, they're a network, and really DBT is designed to try and shift the system, how you're feeling, what you're thinking. It's shifting many symptoms at the same time. So the capacity, what they found is really the capacity to modulate emotions was a central mechanism, was a key finding. These researchers found that in particular, reductions in anger and irritability produce the biggest ripple effects across the system. So that was important. They also found that identity consolidation improved with DBT skills. So improvements in unstable self-image and shifting perceptions of others. And they also found that DBT skills training seemed to create a systemic change by weakening symptom to symptom connections. So perhaps in terms of, think of what are clinical implications, maybe the implications are maybe beneficial to prioritize emotion regulation, distress tolerance, with a particular focus on anger and irritability and identity because they have the biggest impact on the broader system. I also want to highlight another study, and this was a study, we don't usually talk about defense mechanisms in DBT, but if we drop the jargon, really defense mechanisms are simply an automatic way that people protect themselves from emotional discomfort. And they're theorized to be a common change process across therapy approaches. So this was a study conducted by Sebastian Euler, and it was in the context of DBT skills training. And what he found is that DBT skills training led to better overall defensive functioning and reductions in borderline type defenses. And this was compared to a treatment as usual condition. So in other words, borderline functioning is more dysfunctional ways of coping with emotions. That's what was decreasing and associated with change on outcomes. There was also a finding that increases in narcissistic defensive seem to predict worse symptoms at discharge. So I think, why I highlight this study, I think, first of all, it shows that the findings that this idea of defenses and change in defenses is not unique to psychodynamic therapy. And what it also really highlights is when people shift from less dysfunctional ways of coping with their emotions and emotional distress, that seems to be associated with better outcomes. So I think importantly, the study, supports a more integrated view of how psychotherapy works. And I also think that it is important because I think it highlights a need for research that targets maybe broader trans-theoretical mechanisms. So not just mechanisms tied to a single treatment model, but if we're going to understand how change works in treatment, it can be really helpful to look at what processes reliably predict improvement, maybe regardless of the therapy package, and also figure out maybe what's essential and what may be model specific, but perhaps not necessary. So, and then finally, I want to say a few words about the therapeutic alliance and validation. And certainly it's well known, this is a theorized trans-theoretical mechanism of change. I think most people acknowledge that the therapeutic alliance is a foundation for all other strategies in treatment. The therapy relationship, it's really hinges on the ability for your client to be engaged, for a client to feel, to have a relationship with their therapist. And so certainly the findings from DBT are consistent with the broader literature. Across several studies, there's evidence that the stronger the therapeutic alliance, the better the treatment outcomes. So there was an earlier study by Beedix who looked at DBT compared to community of treatment by experts, found that the strength of the therapist-rated alliance predicted lower suicide attempts on outcome, and the strength of the client-rated alliance predicted lower levels of non-suicidal self-injury. And this was true in DBT, but not in the community of treatment by expert condition. From the same study, another secondary analysis of this data, they found that therapists who were experienced by clients as being affirming and protective themselves increased their own self-love and self-care, and in turn showed lower levels of non-suicidal self-injury. We did a study looking at predictors of dropout and found that the strength of the therapeutic alliance as rated by the client was the one variable that was the strongest predictor of treatment dropout. And this predicted dropout not only in dialectical behavior therapy, but also general psychiatric management for BPD. Another study done by Turner comparing DBT and client-centered therapy found that, again, strength of the alliance predicted better outcomes, and this was independent of treatment modality. So I think the takeaway is the alliance seems to be an important mechanism driving change. Now, there are a couple of studies that have found negative findings, so I want to highlight these. And they may indicate that the alliance is crucial for engagement, but it may not be a standalone mechanism. There was a study by Emmanuel Lizek, and she examined the strength of the alliance in a DBT skills group. So it was a 12-week DBT skills group, and she found that the alliance didn't independently mediate outcomes. I will say from my own experience, I've never found a great measure of the alliance, or the construct of the alliance is a little different in a group context. Maybe group cohesion, or it's harder to find a measure that really captures, I think, a phenomena that may be comparable to what's defined by therapeutic alliance between a client and a therapist in other studies. So, and then another study by Barnicott found that in this study, alliance predicted reductions, the strength of the alliance predicted reductions in self-harm and predicted retention in treatment. However, when they took into account skill use and self-efficacy, the effect of the alliance dropped out. So that's important. Many studies may not take into account other variables that may be influencing outcome, and it kind of shows that the area is complex. We have to be able to consider multiple variables at any time. This usually hinges on having large samples. And then I would say, bottom line, the takeaway, alliance seems to be foundational, maybe not causal. Certainly it creates, I think, safety, motivation needed for change, but it may not be causal. So when we think of the alliance, it's not just the therapist, but it's also how the clients shape the alliance, and that has an impact on outcomes. So there was an earlier study we did that looked at personality traits, and we found that clients who tended to be more agreeable formed much stronger therapeutic alliances and had much better outcomes. So this was the alliance-mediated outcome and was moderated by the client's agreeableness. But this was true only in DBT, not in a general psychiatric management treatment for borderline personality disorder. In another study, clients who were much higher in levels of depression and feelings of hopelessness or anxiety reported much weaker therapeutic alliances and in turn had poor outcomes. We all know that sometimes it is harder to engage clients who may be more hopeless or depressed or anxious. And then finally, we conducted a study. This is using a multi-level mixed effects model where we could parse out the contribution of the therapist effect on the alliance from the client effect. So in other words, how much of the alliance is explained by therapist skill? You know, some therapists might be quite skilled at developing strong alliances, but we also have some clients who just might be more challenging to engage with. What we found, and this was in the context of a study examining DBT for borderline personality disorder, it was compared to general psychiatric management. We found that early alliance, the first 4 sessions of treatment, the strength of that alliance predicted treatment outcomes. So that was important, those first 4 sessions. However, the effect was largely explained by the client factors. When you measure alliance repeatedly over change, and we measured it every 4 months over this treatment, we found that over time, changes in the alliance were even stronger predictors. But again, they were largely driven by the client contribution to the alliance. So takeaway, the alliance isn't obviously only what the therapist is doing, it's also about how the client's engaging and how the relationship between parties evolves over time. And it may be that the unique client-therapist pairing may matter more than the therapist's general alliance skill. And then finally, I think it's sort of related to the topic of therapeutic alliance. I wanted to talk about a specific strategy in a study, and this is strategy of validation. So we know validation is critical to helping clients, or we believe it's critical to reducing emotional arousal, to building and strengthening the alliance, enhancing motivation, increasing self-validation. So it's assumed to have affect many changes in the client. This is a study that examined how different levels of validation in DBT affect moment-to-moment changes in emotion. And these researchers found that the overall amount of validation was not predictive of change, but rather it was the level of validation that seemed to matter. So those higher levels of validation, so V4 and V5, so normalizing or validating in terms of context, dysfunctional context, sort of how, you know, a person's lived history or the way they're thinking or their biology. Those were associated with increased positive affect and decreases in negative affect. Interestingly, they also found that radical genuineness had the strongest impact on emotional change, whereas lower levels of validation, so your V1, being present, being alert, being awake, V2, so V2 and V3, so straight reflections or reflecting what's not expressed, reflecting emotions. Those lower levels were predictive of decreased positive affect, but there was no change in negative affect. So the bottom line, it seemed that it was quality over the quantity of validation. Higher level, deeper validation seemed to be driving more functional changes in emotions. So these advanced validation skills may be an active mechanism of change in DBT. I know I'm almost at time, so I'll perhaps wrap with a few final words. I do want to say a few words just about the limitations of some of this research and how we can make sense of it. I think some of the challenges are many of these studies are correlational. So we're not really drawing any strong conclusions, or we can't draw conclusions about causality. Much of this evidence is coming from secondary analyses of randomized control trials. And it usually means that a lot of the studies have not really been well designed to test mechanisms, because measurement timing is really important when you're conducting a mechanism study. The more frequent you're measuring your phenomenon, often more useful it is. And often measurement timing is suboptimal in these studies. I would also say constructs like coping skills, and you saw I talked about several studies that talked about increased functional coping and decreases in dysfunctional coping. These terms are very broad, and they're also quite inconsistently defined. And it does make it quite unclear to really know, well, what skills are actually driving change. There also tends to be in the literature quite a high reliance upon self-report. And that limits conclusions about real world behavior. So I think bottom line is the evidence for mechanisms in DBT, it's promising, but it is preliminary. We need more precise, theory-driven, and also temporally sensitive studies that can really identify true mechanisms of change. What are clinical implications of this research? I think one is that DBT mechanisms likely operate as a system, and we saw that network analysis, that certainly was true. They're not operating in isolation, even though we might study things sometimes in isolation. It seems certainly the alliance is important. It seems to be linked and certainly a predictor of outcomes. So in terms of implications, I would say important to build it early, repair it, important in terms of probably driving engagement. I think focusing on mindfulness with particular attention to non-judgment. Again, we're seeing that facet continuously come up as a predictor of outcome change. We also saw from some of the studies on coping skills that there seemed to be some evidence to suggest that the earlier to prioritize increases in adaptive coping, the better. And then prioritizing using skills frequently, not that probably most of us don't try and do this with many of our clients, but at least it might be something to highlight to your clients, to share with them that there is evidence that the more they're using their skills, the better the outcomes. I also think another implication from some of this research is to really lean in to more emotion-focused work in DBT with a real focus on trying to help people increase their awareness, their acceptance, in particular of adaptive primary emotions as a mechanism of strengthening overall regulation and improving outcomes. And we can see some evidence that higher level of validation, maybe in particular, especially radical genuineness, seems to be very relevant and linked to improvements in emotion. So I will, at this point, maybe thank you for your attention, and I'll stop here and allow people an opportunity to ask questions.
Well, thank you, Shelley. That's fascinating. It's a bit like looking under the hood of DBT, right? Into what's going on there. And I think it's very relevant for us, not just for researchers, but especially for practitioners, right? To know what is actually happening when we do those protocols. So I think we can have a discussion now. There's many things to talk about. I haven't seen any questions yet on YouTube, but I do have some myself. Let me just recheck if anything has come in. I have to refresh that. What I was actually going to start with, my first question for you could be, let me come back to the Zoom. I'm wondering about didactics, about the skills group. Maybe are you aware of that? Do we know anything about how skills group should be conducted? I mean, does it make a difference what the skills trainers do in the group, how they teach?
Um, it's a good question, and there may be literature out there. Again, this isn't an exhaustive review, but I can't think of a study offhand that
Hmm.
addressed, but I'm not sure if you're asking about studies that may have tested
Yes,
how
yes.
the order with which skills are taught. Um, so I'm not aware of a study that has examined, how the
Hmm.
skills are taught and any differences in terms of, um, whether your teaching
Hmm.
style as a
Hmm.
mechanism of change. But I will say that I've largely focused right now on client processes
Right,
rather
right.
than therapist factors. And
Yes,
so
yes.
there is likely literature I've missed there on therapist
I
factors.
I haven't seen any either about skills
Yeah,
group, but I'm not sure
yeah.
whether there is any. Yeah, that's maybe something to look for.
Mhm, mhm,
Um, so one thing about from your talk, I thought it was very interesting. You had this data about anger and irritability as being
mhm,
sort of a
mhm.
key emotion that seems to make a difference. I was surprised. For my intuition, I was more thinking about fear before coming to this webinar. Could you comment a bit on that? I mean, how firm is that evidence, and do you think that's plausible? I mean, does that reflect your experience, the clinical experience you have?
Uh, It's a good question. First of all, this is one study that
Hmm.
that showed this finding, and it was one network analysis. Um, uh, why might it be that the reductions of anger and irritability had the biggest impact? Uh, um, again, I'm making stuff up. So this is just theory. This is just my hypothesis is that it's entirely possible that actually, to the extent that you're reducing your anger and irritability, you are in turn increasing your ability to tolerate primary adaptive emotional
Hmm.
experience. If we
Okay.
think of often anger and irritability, often, not always, especially in a lot of our clients with BPD, it's a secondary emotional response or an escape behavior.
Hmm.
And to the extent that people are reducing that escape from their emotions um, and able to tolerate and increase acceptance of primary emotional
Hmm.
experience, um, that allows for a lot more openness to change.
And opening sort of the stage for a more balanced spectrum of
Yeah.
of emotions, right? Yeah, that makes sense. Okay. Hmm.
I mean,
Right.
to add to the fact that perhaps reducing anger and irritability also probably has a huge impact on your interpersonal relationships and your
Right.
environment. And in turn, your environment can respond to you quite differently. If you're not biting people's heads off, then likely in turn, you're getting reinforced perhaps in ways that also promote your change.
Hmm.
I mean,
Yes,
and
and
this
I'm
is
also
where, no, sorry.
yeah, sorry. Again, this is probably it's not evidence based, but I'm wondering how much there also might be a cultural component, whether there are maybe some cultures where the clinical how can I say sort of the clinical phenotype might be more anger dominated or less anger dominated, depending on the culture where the individual lives.
Absolutely. I mean,
Hmm.
that may be a factor.
Hmm.
Absolutely. I mean,
Yeah.
I did think, sort of on a related note, the finding by Uli Kramer was important, that to the extent that people can increase their ability to assert anger, so primary anger rather than secondary, um, explosive anger, that actually drove change. So I think that sort of corresponds to this idea that if you can eliminate a lot of these escape emotions, and increase the ability to be with, sit with your primary emotions, that other change is possible.
Yes, yes. I do have something on the YouTube chat that I'd like to put to
Sure.
you. There's a big thank you from Anna. She says, thanks for a very interesting and inspiring webinar. But she doesn't have questions at the moment. She just wants to express her gratitude. And that's from Sweden, from
Well,
Anna
that's nice.
Lindström
Thank you.
in
I'll take
Sweden.
it.
Yes, and then we have, I'm not sure about the name here, but I'll read the question. And there's also a big thank you. Thanks a lot for your talk. Is there any evidence which of the modules in skills training are most effective?
I don't think we have, I mean, I wish we did, and I think there are researchers beginning to examine that. I, there's not a there's no conclusive research that I think would allow us to say that one module is more important than the other. Certainly a lot of research has been done on mindfulness, and certainly theoretically, mindfulness, it would be hard to utilize other skills if you're not mindful. So one would assume that your capacity to be aware is required to engage in other behavior. So there's not, but again, there's no research that sort of said this particular module. And I think at the end of the day, we want to be thinking about what particular process for which particular client, because it may be that some clients, depending on their symptoms and what's going on for them, that there may be particular processes that need to be shifted a little bit more than other processes.
Yes, yes. Let me recheck. Maybe there's something more. We're approaching the end, but maybe we might have time for some more questions. I just have to refresh the page. I don't think anything has come in. Anyway, me personally, I thought that the validation bit also was fascinating. That was surprising that even the level of validation seems to make a difference, and maybe we can know more about this in the future, and we can validate in an even more sensitive way.
Yeah, I think it is, again, it's a single study. More research is needed on that finding, but I think it's worth further exploring.
Yes, yes. Okay, well, since time is almost up, is there anything that you would want to add, or should we leave it here with those mechanisms?
I will just say thank you for having me today, and hopefully this was helpful to people.
Well, thank you so much, Shelley. I believe this is really relevant for all of us, and you've given us some very good insight into what we are doing and maybe where we should look at closer in the future. So many thanks for your fascinating
Thanks,
talk.
Jan.